Hi there, good morning. My name is Otis Toussaint, and I'm coming to you live from the Office of the Surgeon General here in Washington, D.C. Today, we're talking about the operational quality and safety in an operational environment. Today, it's the AUSA virtual conference, and I'd like to introduce you to an illustrious panel of Army leaders that are involved in the quality and safety of our Army. And I'd like to introduce you all to them, the entire panel. Well, actually, no, let's not go with the entire panel. Let's go first and foremost with our first Colonel Tonya Dickerson. Hi, ma'am.
Good morning. Good morning. I'm Colonel Tonya Dickerson, Deputy Chief of Staff for Quality and Safety. On behalf of the entire Quality and Safety team, we are honored and excited to present today in this live panel centered around what the team has accomplished during COVID-19 and prior as we look at the role of quality and safety in the operational environment. We have two dynamic Army leaders and subject matter experts today who will be presenters on the panel. Colonel Bonnie Hartstein and Colonel Karen Smith. Additionally, our SMEs in our various quality and safety fields are also on the line. Today, we have three main goals. First, introduce our new programs that have been very instrumental in ensuring quality and safety is always at the forefront in everything we do, especially during COVID-19. Second, answer any questions you have about the presentation or a related topic. And third, display the importance of collaboration and communication. I am now going to turn it over to Colonel Hartstein and Colonel Smith to introduce themselves and present the presentation. We are honored and humbled to have been selected to present to you quality and safety in the operational environment.
Thank you, ma'am. Thank you for adding on those two personnel. First, we will go with Colonel Bonnie Hartstein. Oh, you're mute, you're mute. There you go.
Good morning, everyone.
Good morning, ma'am.
Good morning. I'm Colonel Bonnie Hartstein. I'm the director of the AMEDD Quality and Safety Center. I'm going to be talking to you today about some of the innovations that we did in quality and safety, and specifically in the areas of credentialing and privileging, which are really an instrumental way to make sure that all the healthcare professionals who treat our patients are skilled, competent, and appropriately qualified to do that. Otis, will you be able to show the slides while I'm talking? Because I can't see them.
I am, ma'am. Let's go ahead and actually, before you go into the slides, ma'am, I'd like to at least have everyone get a chance to see the entire panel that we have today.
Oh,
and then
okay,
we will jump right into the slides. So
super.
I'd like to take the opportunity. Let me shift over to me real fast. I'd like to take the opportunity for everyone to see the illustrious panel that we have today. So here's a live shot of the entire panel that we've got going on today. Say hi, everyone. There you go. Good morning to everyone. And we've got first in the chute, we've got Colonel Hartstein. So let's go ahead and put her solo like that, and then add her screen like this.
Great. Okay. So I'll get started here with our presentation this morning. If you can go to the first slide, next slide, please.
Yes, ma'am.
Great. So I'm going to go over credentialing and privileging, specifically related to how it relates to readiness and what we've done in terms of the innovations we did in the space of COVID to get a process. Credentialing and privileging sometimes can take, if you're familiar with it, a long time. And in COVID, we had to act fast. And so some of the work we had done in the past laid the foundation to enable the quick response that we needed in COVID to get the right people in the right places to do the right job and offer that fast medical support that was needed essentially worldwide. Next slide there. By training, I should mention, I'm an emergency medicine physician. I'm the consultant to the Surgeon General in emergency medicine. So credentialing and privileging, like any physician or any healthcare professional, is something that you experience again and again in your career as you move from place to place. So I want to sort of set the stage here by establishing a few definitions so we're all on the same sheet of music. Credentialing and privileging, while they're said together and often used interchangeably, are actually two parts of a very distinct process. If you think about going to, get your driver's license, if you figure out your driver's license is your permission to drive on the streets of the state where you are, that would be your privilege. Your credentials are all the documents that validate your competency and show that you should be allowed to do the craft or the skill that you do. So these are your licensure, your certifications, your board certification, your all the things, your residency certificates, all the things like, your birth certificate, your driver's ed form of completion. These are your items that show that you have that background to do it. Now, privileges involve validating all the credentials and also making sure that you're competent and you're skilled, and then it's the permission to actually deliver the medical care. And this is related in a large part to our accrediting agency, the Joint Commission, that's responsible for making sure that that we use it to validate the quality of our hospitals. And privileging is an important element of that quality. It ensures that the platform of care has the right, you've identified the right scope of care that can be supported by that platform of care, and that the people working there have the right permissions to do the care that they can. If you take, for example, a transplant surgeon, not every hospital can support transplant surgery. So you may have the credentials to perform transplant surgery, but you don't have the privileges or the permission to do it in this hospital because we don't support it. So that's the way credentialing, privileging kind of go hand in hand. The privileging authority is the person who gives you that permission. So this is a very important leader in the chain of credentialing and privileging. They give you the final green light. And that usually is the MTF or hospital commander. In the Navy, it's the fleet commander. And then I'll go over a little bit about the way the services do this differently. But we don't send doctors downrange or even into hospitals without giving them privileges. So this is a very important step to getting the medical care to where it needs to be. Quality oversight. This is the general world that we're going to talk about in all aspects this morning. But this is all the things that we make sure that the quality of care the patient gets is sound, is good, is delivered by qualified individuals. And that's part of the essential front door of that of any organization is the credentialing and privileging. Who are you letting into your facility to see your patients, and are they skilled, and have you vetted them appropriately? And this happens in accordance with these regulations. So let's go on. So now that we're all on the same sheet of music with what it means to be credentialed and privileged, we're going to jump into the next slide here and go into the Army Reserves. So how does this relate to our Army Reserves, and how does privileging tie to that absolute #1 priority of readiness? Next slide here. The AMEDD Professional Management Command is a reserve command, and they are responsible for that important step of credentialing all Army reservists. So they gather all of the documents that the reservists need to make sure that they're ready to be privileged when they come on active duty. And this is an important distinction in the way that the Army is managing, and as we're making some changes, we're trying to change in this space. But the Army had been traditionally for the reserve component, and I'm not going to go into the National Guard. They do it a little bit different in the National Guard, but to focus on the reserves, they will credential all of the reservists, but not privilege them until they have orders to go somewhere and do a mission. So that important extra step of privileging, so important in terms of giving you the permission to see patient care, could sometimes take a long time. And and if you think that, readiness is tied to your physical readiness in terms of being able to deploy, as well as your competency to do your downrange job, this is yet that other step. You're not even allowed to do it until you're privileged. So let's go into the next slide here. This kind of sets the stage for the issue, the mission set, the problem set that we were facing. In order for reservists to really be ready to pop and deploy, they have to be privileged. But we were waiting this step, this extra step of privileging, which was going through the MTF where the reservists were going to deploy through. So the platform of deployment was the location where they were going to get privileged, where the hospital there and that privileging authority was going to grant them their permission. Now, they weren't going to work in the hospital, but they were going to take those privileges and work downrange. So it was a little bit, it's still there, but we have done a lot to create a different process, because this process sort of put the most important step all the way to the end, and it could become the rate limiting step of the most important item of getting on, situation, getting on the plane, going downrange, doing your skill set was tied to privileging, and privileging was too far downstream. So APMC would get all the documents together, the reservists would get orders and go to the deployment platform, and that's when the privileging would happen. So we endeavored to create a process where we would privilege reservists before they even had orders. The Navy, the US Navy does this, where they take all of their reservists, and without the pressure of a deployment, they're vetting them and giving them privileges so that when they're ready to go, they are ready to go. And that was the problem set and the solution that we were trying to emulate. Next slide, please. So you can see here, the Interfacility Credentials Transfer Brief is the document that initiates that privileging action. And the timeline that APMC was going off was 120 days beforehand, then 90 days, and all these things had to happen in order to send the right information to the MTF where the provider would be deploying through in order to get those privileges. But you can imagine, not every conflict do you have the luxury of time. And certainly in the space of COVID, we did not. Next slide, please. So what we did was, instead of having the active duty MTF commander be the privileging authority, we brainstormed and came up with an idea to have the APMC commander be the privileging authority. And the Surgeon General then of the Army was able to then delegate that privileging authority to the APMC commander. Then reserve privileges would be privileged for deployment through the APMC commander. And then if they were going to work in an MTF, well, then because of Joint Commission requirements, they would have to be privileged by the MTF commander. But most of the time, that wasn't the case with the reservists. They were being deployed. Go to the next slide, please. And this is the delegation memo, and it's been reissued by our most recent Surgeon General, General Dingle, but Lieutenant General West had signed one before this. Next slide, please. So how did this go during COVID response? Well, we had already set the stage and already privileged about 70 reservists to do their downrange mission. But when COVID hit, there was a need to rapidly spin up and deploy reservists to meet stateside and worldwide missions. Because the APMC commander had that delegation memo, the APMC commander was able to issue disaster privileges to activate reservists. Now, I'm going to go into, in the rest of my presentation, what are disaster privileges and how were they leveraged to mobilize a number of different providers to do different things during COVID. But disaster privileges were one means that are available to get people that permission to see patients very rapidly. But the caveat is you have to be a privileging authority to issue disaster privileges. You have to be able to have that approval authority. And we had luckily done this project and had the APMC commander staged as a privileging authority. That enabled rapid deployment of the reservists to meet this mission. And we have now this new process in place to support our centralized process, which we're getting spun up in terms of any response worldwide with reservists. I will mention that the National Guard has privileges, but they have privileges to work in their state. So in order for them to deploy, we will be leveraging a similar process into the future after we get this pilot off the ground with the reserves. Okay, next slide, please. So now let me talk about some innovations in credentialing and privileging in general at the DHA. I was, during the time of COVID, had just been tasked to serve as a to serve in a capacity at the DHA, leading up the credentialing and privileging function there for a 6-month stint assigned to DHA. And that happened just at the same time that COVID hit. So we did a number of things quickly at DHA also to have the that worked to empower the entire MHS to spin up during COVID in the way that it needed to. Next slide, please. So I'm just going to go over those credentialing and privileging process changes in support of COVID. So at the MTF level in medical care platforms, or even deployed platforms, there were a number of different processes that we put in place or changed to enable rapid sharing of providers, spin up of providers who were not already privileged to work, and then how to handle those that needed to be repurposed and working at the top of their license or undergoing just-in-time training. We had to cross-level providers to work in ICUs. We had to take primary care providers or even specialty providers, put them in triage tents. There was a lot of rapid movement of medical professionals into areas that they may not otherwise have worked in. And that required some thinking through, because we usually are pretty particular about giving permissions or privileges to work in a very specific area. In COVID, that whole thing got very challenged because we really needed to be able to leverage people against the skills that they may have learned a while ago, but were ready to kind of spin up and use in this emergency situation. We had situations where we couldn't offer BLS and ACLS classes. These were prerequisites to privileges, and if they expired during the normal course of one's practice in a normal non-COVID environment, people would not be able to practice care. But clearly we're not in the middle of a pandemic response we weren't able to have regular BLS recertification classes. We were having people's license come up for renewal, and the state license board was not able to meet. So this became a problem. We had to rapidly expand the capabilities of telemedicine. We had worked, again, another project to have centralized privileging for the space of the virtual medical center, and that got accelerated and a jump start during COVID. And then we also had situations where people's privileges were going to expire, and then the delegation of the privileging authority. I explained during the reserves that the only individual able to award privileges is the privileging authority, and that's the MTF commander. Well, during COVID, the MTF commanders had a lot on their plate. And we recognized this, and when it was all hands on deck, we had to allow a pop-off valve for the privileging authority to be able to delegate privileging to another senior level advisor in the chain of command, so that the privileging authority the privileges could get awarded in the timely fashion that they needed to. And then, of course, when the balloon went up, we had to be able to disaster privilege people and get them into practice quickly if they weren't privileged, and to extend those expiring privileges. But I have those on the other side of the lightning bolt there to show that these were really only when and it didn't take long to get there, but we did get into a place where these, which were only really reserved for the most dire of circumstances, well, we were pretty much there everywhere. Even if people weren't overrun with patients, we understood that the disaster plan, even a portion of it, would enable folks to start, or the privileging authorities to start issuing disaster privileges as needed. Next slide, please. So I'm going to go over these in a little bit more detail each and just explain how they were utilized. A question came up, well, what if I train people to do something that they don't normally do? We're going to be doing some just-in-time refresher training and asking maybe ward nurses to work in the ICU, maybe internists who are normally in practice in the clinic to call in the intensive care units, maybe even manage ventilators. They haven't done it for a while. Well, there was a question, do we have to issue disaster privileges for this? What kind of documentation do we need? And I'll show you on the next slide with the Joint Commission that there is a mechanism and an allowed process during emergencies to expand within people's training and certification the work that they do. And so we said, no, stand down, don't issue new privileges to everyone. That's a lot of paperwork that's not going to be used, that is going to be a distraction. Do the just-in-time training, get people where they need to do within the scope of their license, and that's going to be fine. Disaster privileges we used when we had returning retirees or in the reservists who didn't have privileges but were having to work and be able to be permitted to work quickly. So that there was a space for disaster privileges, and that was what we used disaster privileges. And then we also leveraged another legacy Navy process called privileging by proxy, which enables providers to move between platforms of care where they would otherwise have to get privileged, to just kind of show up and with the acceptance of the privileging authority with one signature to be able to use the privileges that they have to get into practice. And we were able to quickly stand this up for the Air Force and the Army. And then we had, of course, MHS providers who might have been returning to practice. Perhaps they were in administrative assignments. They hadn't practiced for years, and they were able to be issued supervised privileges or disaster privileges if they didn't have privileges. Next slide, please. So this is just the Joint Commission's regulation that says that in an emergency, any staff member with clinical privileges is permitted to provide any type of patient care, treatment, and services necessary as life-saving to prevent serious harm, regardless of his or her medical staff status or clinical privileges, provided the care, treatment, and services are within the scope of the individual's license. Next slide. Privileging by proxy. So what is privileging by proxy? Privileging by proxy allows an institution to accept that privileging decision by a different privileging authority and pretty much get to work with the acceptance just of the local privileging authority. Privileging by proxy is authorized under our new procedural manual and had been used by the Navy since 1994. We also use it in telemedicine. And so we were able to replicate this. Our actual electronic credentialing system, CCQuas, did not support it for the Air Force and the Army, but I'll show you here in the next slides, we created some fillable forms that were able to kind of do that trail that we needed to do the right work to show the permissions that we were granting. Next slide, please. And here's the fillable form that we were able to rapidly put together and put on a SharePoint site and let people then, within markets, the newly formed DHA markets, this turned out to be very important, especially in areas like Hawaii and in the Washington, D.C. area, where they had to cross-level resources. This otherwise would have just been a bit more of a paper trail. And I know we're getting into a few of the details that you may say, well, what does it matter? It's a pandemic. Let's just go ahead and do it. Well, that's true. And this enabled us to just go ahead and do it. But we do still have to adhere to quality and safety and make sure we know who's working where and that they are who they are. You certainly wouldn't want not completely imposters to be treating you. So we do have to still make sure that that quality is maintained. So here's our fillable form. Next slide, please. We did a lot of these new things, but and so we wanted to make sure though that there was a tiered response and people weren't just jumping to these disaster privileges and necessarily without cross-leveling people that were known and vetted individuals. I mean, people were showing up at the doorstep of hospitals saying like, I'd just like to help. And we wanted to make sure that we knew that was going to be necessary if it was really all hands on deck. But with a worldwide medical staff, we should be able to cross-level our folks and send people to places to help out. And this was how we asked our commanders and our leadership to use a tiered response. So first, you're going to cross-level the folks that are in your own facility. Then you're going to privilege by proxy to add and share providers throughout regions and across regions if we need to. And then at the very last ditch, we'll do disaster privileges for civilians in the community who may want to give a helping hand to an overrun hospital. So that was something we also were clear to explain about. And then in operational units mobilized for COVID without embedded privileging authority, we had to figure out how to quickly stand those guys up. And that was where we were using the disaster privileges for reservists, and pretty much any proof of identity would enable you to work in disaster privileging. And this was a Joint Commission regulation that we were following. So that means if you're really completely at DEFCON 0, you've got, absolutely out of Schlitz, needing people from the community. If they show up with their Methodist badge, you could give them disaster privileges. Of course, this required a recheck, starting to validate who that person was within 30 days of the work that they were starting. So there wasn't just a carte blanche, anyone could treat patients, but we were getting close to that in some areas. And so we at least even had to address that. Next slide, please. Now, telemedicine, again, we said telemedicine became a really important tool during COVID response to extend care to patients at home and to protect physicians or providers who may not have needed to come into the office and face-to-face see patients. So how do you rapidly enable people to provide telemedicine? Well, in our current regulations, if you're going to see your own patients virtually, you don't have to do anything different. There's some telemedicine training that the Army has in place that just introduces people to some of the technology, and we ask that people did that. But otherwise, just your own patients, no barrier. But if you're going to be leveraging cross-facility providers to see other people's patients, or to provide even like remote tele-ICU, all that by regulation requires a privileging action. Well, again, just like the reservists, luckily we had already leaned forward with the virtual medical center and created a centralized privileging authority through the virtual medical center. And in the space of COVID, this was able to get accelerated. So one privilege through the virtual medical center would enable you then to see patients worldwide. Next slide, please. And here we have our tiered telehealth for COVID, and this was signed by Lieutenant General Place, enabling the rapid expansion of telemedicine services during COVID as well. Next slide, please. This was the memo. This is just a little bit more about the delegation of the privileging authority, where we enabled the privileging authority to be delegated within the MTFs to individuals that were able to, another senior leader member appointed by the MTF director, maintained in writing, who was going to be able to grant, renew, and extend privileges. Now, this did not extend into the healthcare risk management section of the House, and the responsibilities to do that were going to be maintained by the privileging authority. Next slide, please. And then extension of licenses, I mentioned this. Some states were allowing providers to extend their privileges beyond their expiration date, and I also assisted with information related to that. Sorry, there may be a lot of dog barking. Someone's outside my house, and so we have a lot of activity suddenly this morning. Next slide, please. Next slide. I think that may bring us to the end. So I am going to now turn it over to Colonel Smith to talk about the Vital T program, and then I will be available for your questions at the end of our presentation.
Good morning, everybody. My name is Colonel Karen Smith. I'm the Director of Patient Safety at the AMEDD Quality and Safety Center. I've had more than 4 years of experience in quality and safety, but I am also a physician by trade, a reconstructive urologist. And in 2009, I volunteered to deploy to Iraq, where I served as the OIF urology consultant. During that time, I received many calls from throughout that area of operation asking for assistance. But one particular call has always stood out for me. A female OBGYN or gynecologist deployed forward with an all-male line unit trying to rule out testicular torsion or twisting, and this is a surgical emergency. Oh, and by the way, this was during a sandstorm where she could not air evac the patient. So at that moment, I became aware of the true risks associated with remote healthcare, the importance of that connection with the SME or the subject matter expert for both the provider and the patient, and what my responsibility was as a leader. Years later, I was asking the same question from a quality and safety perspective. How can we improve access to subject matter experts for those in remote clinical settings in order to ensure the safest healthcare environment to our patients and staff? Today, I'd like to introduce you to our Vital T program, an innovative program which brings quality and safety experts to remote clinical sites utilizing the pre-existing virtual health platform. This program was originally developed and piloted within Regional Health Command Europe in order to address challenges with geographic remoteness of clinical sites and resource constraints, potentially limiting access to quality and safety subject matter experts. And we originally developed this as a continuous survey readiness tool. We have since tailored this program to the theater environment, hence the Vital T in the acronym, in order to maximize access of these remote deployed units to quality and safety subject matter experts, such as infection prevention and control, patient safety, and medication safety, as well as other subject matter experts, such as immunization healthcare management personnel, with the ultimate goal of enhancing the safety and readiness of our service members. You may notice that the acronym includes the word inspection, but the goal is enhanced access. How can we support those in remote healthcare settings in the operational environment? Not about inspection. Today, I will provide an overview of this program as well as some of our experience. Next slide, please. Next slide, please. Thank you. But first, the why. Why is this important? As we move toward high reliability, harm prevention needs to move far forward at the site of first patient contact. Prevention of harm during healthcare delivery impacts patient safety, staff safety, and ultimately the overall readiness of our service members. We want to ensure that our service members don't develop infections from being in the hospital and don't have adverse events from a treatment. And we want to learn from those patient safety events that do occur so we can prevent that next event. We want to ensure a safe healthcare environment and keep service members in the fight, therefore preserving readiness. So we need to start with targeting high-risk areas and processes. Next slide, please. The role of quality and safety in the operational environment is evolving. We know that it can have an impact on readiness, and we are seeking to apply the same standards of care in the operational environment as in the garrison environment. Risks to patient and staff safety exist within the operational environment. For example, even before COVID-19, multi-drug resistant organisms were a threat in the deployed environment and have been for years. Quality and safe care delivery is one of the most important variables we can influence in this unpredictable setting. So we as leaders are responsible for providing these tools which maximize access of remote clinical sites to our subject matter experts because they are essential for the safety of our patients and staff. Next slide, please. This program was originally born out of challenges we recognized during preparation for a Joint Commission visit at one of our overseas military treatment facilities back in February 2017. Achieving survey readiness was a challenge not only due to reasons experienced by most healthcare systems, such as lack of accountability, poor communication, etc., but also due to unique challenges we experienced due to our environment being geographically dispersed and resource constrained. Specifically, we needed to prepare not only at the main hospital, but also at 6 outlying Army health clinics located across 3 and TDY funds, so resource constraints. Our quality and safety lane therefore developed this program as one potential mitigating strategy. We subsequently conducted a successful proof of concept pilot focused on infection prevention and control, and based on conducting virtual assessments of 6 remote clinics by an infection prevention and control subject matter expert located centrally. We demonstrated both savings of money and time. Our long-term vision, however, was to develop this for the operational environment, as we knew that they had the same challenges as remote sites, and we did just that. Next slide, please. So our original construct, how did we do this? We required a very basic setup: camera, laptop, plus or minus a rolling cart. And here we see the infection prevention and control subject matter expert is conducting the virtual site-assisted visit from another location through the computer, while designated POC at the remote clinical site maneuvers the camera. In theater, our options for connectivity have increased recently with the use of MC4 computers as well as other devices such as DX80s. Next slide, please. So our program currently offers virtual support in infection prevention and control. However, we've developed this also for patient safety as well as medication safety. The VitalT program currently offers the following services: not only virtual SAVs or site-assisted visits, looking at patient care environment or process, but we've expanded this to help folks do virtual coaching, education, and/or training on quality and safety and other subjects. We also offer virtual patient safety support to include support with patient safety events or root cause analysis, so that we can get to the root cause of events and prevent them from happening again. During COVID-19 response, we modified our program even more to create on-demand service for those mobilized CONUS, for the DISC mission, as well as those located overseas. We added medication safety as a specialty, and we also added an email address and a 24-hour hotline, which I personally man. Next slide, please. The objectives of our program are as follows. We talked about improving access of remote clinical sites or operational units to subject matter experts. So essentially, we are utilizing virtual health capabilities as a force multiplier of our assets. Facilitating learning via the link-up capability. We know that multiple sites can dial in and learn from one event, one virtual event. We thought this was a very valuable potential tool for education, coaching, training for remote clinical sites. And for the last part of our original pilot, 2 sites dialed in at once, sharing information from each site. Decreasing disruption to the mission at the host site due to an in-person SAV. We can execute spot checks at the originating site's convenience, saving time and money. Virtual health for direct patient care has shown this time and again, and we did as well with our pilot. Saving time and money due to TDY travel and loss of productivity, as well as being cost-effective, utilizing pre-existing equipment and technology. Decreasing risk associated with travel within theater, and obviously ensuring continuity of access during travel restrictions, as we've seen with COVID-19 outbreak. Next slide, please. So we are utilizing virtual health technology in a different way. Many of you are familiar with its use in direct patient care. As Dr. McVeigh stated yesterday in his address, we use technology as an enabler. We work hand in hand with virtual health to enhance and sustain readiness. We utilize the Cisco platform utilized in Europe for direct patient care, which provides us with a dependable and secure venue. Next slide, please. So as we tailored our original program for the operational environment, we considered possible interconnectivity scenarios and how we could best utilize them based in part on our experiences during the original pilot. Our vision was that VitalT would be a potentially valuable tool, not only for virtual assessments by a CONUS-based subject matter expert, but would also have value for intra-theater consultation and education, with sites supporting each other and multiple sites being able to dial in at once to share information. Next slide, please. So how would this actually work? What are the interconnectivity options and how could we utilize them in practice? So the location of the subject matter expert would be irrelevant. The site of the virtual site-assisted visit could be at the Role 3 under the direction of the CONUS-based subject matter expert in the States, or again, could be at the Role 2 directed by the Role 3. The virtual SAV could be scheduled as directed by the SME or on demand. And the same construct could be used during virtual education, coaching with multiple sites dialing into one session. Next slide. One thing we have discovered over the years is that collaboration is key, and we have partnered with many entities to include virtual health, IT, JTS, combatant commands, and our sister services. During the COVID-19 outbreak, we were asked to partner with the DHA Tri-Service Infection Prevention and Control Tiger Team, allowing us to expand our service to the MTFs. This partnership allowed enhanced access to this joint team of subject matter experts in infection prevention and control, both in the operational environment and in garrison. Next slide, please. So we have demonstrated successful use of virtual technology to address potential risks associated with healthcare delivery within the operational environment, maximizing access to quality and safety experts through patient care virtual health capabilities. The Vital T program is a low-cost, efficient, and safe means to positively and proactively affect the physical strength and readiness of our warfighters, with unlimited potential for future application within the joint operational environment. The way forward involves multi-organization, tri-service collaboration, utilizing available technology as an enabler in order to improve quality and safety during patient care delivery for both patients and staff, which will enhance and sustain readiness. We are one team for the patient, regardless of the uniform they wear. Next slide, please. So I thank you for your attention. We look forward to collaborating with you. And if we could go to the next slide, here's some contact information. And the final slide, subject to your questions, that concludes my talk. Thank you.
Awesome, awesome. Let's see, I think everyone is back on. That was a really good presentation. We do have a couple questions for the presentation. And of course, if you're watching our discussion right now, go ahead and type your questions out, and we will actually post your questions on the page as well and try to best address your question. If the question does not pertain to the discussion, we will ask you to email us a question, and I will provide that information at a later time. So the first question that I have for the panel is, let's go ahead and post it. What are some of the ways you can leverage virtual capabilities for patient safety in the operational environment?
Thank you for that question. That's an excellent question. And I'm going to defer to my subject matter experts, Ms. Phyllis Torr and or Ms. Joan Ruddle-King, to expand on that.
Good morning, everyone. I'm Joan Ruddle-King. I'm one of the nurse consultants for the AMEDD Quality and Safety Center. That's a great question. And I would have to say that what we have found in this journey using virtual health to leverage our quality and safety, we have done so in so many venues. One is to actually use as a platform for team training to prevent events by building stronger teams. I know Ms. Phyllis Torrey, I don't think she was able to actually get onto our platform today. Also, we use this to do coaching and across the enterprise, both in the operational environment and also within our facilities. We did one root cause analysis, our first virtual platform root cause analysis for an event. And this was very, very successful because it brought the subject matter experts together, the charter team that was looking at how to prevent and correct process issues, again, to provide that quality and safe care. Other venues that we have looked at for Compo 2 and 3, is to look into training venues with Compo 2 and 3 to actually provide subject matter expertise to look within their care environment setups, and also to provide that on the spot so they're not alone when they're looking at how to provide safer care. Lastly, in some of the operational environments, also to include the COVID environments, providing that just-in-time training, and then also follow-up on the virtual venue. So I hope that kind of answered the question. If we have any other comments, over.
Any other comments? Anyone wants to add to it? Go ahead and raise your hand and I'll let you chime in. No one, no one. Okay, so we've got a second question. Let's go ahead and post the second question. It looks like the audience is also do have, I see 2 comments there. So let's go ahead and see. The second question is, how do we train individuals to manage infection prevention and control programs in an operational environment? Anyone who'd like to join in with that?
That's another excellent question. Thank you for that. I'm going to defer to Ms. Helen Crouch, who is the Army Lead for Infection Prevention and Control. Ms. Crouch?
Hi, good morning to everyone. This is a fabulous question and interesting because of our recent training. So there is currently a formal 5-day infection prevention course specific to deployment or humanitarian missions that are held at TRADOC. That is held 4 times a year. And this was based on our previous deployments back in 2008 and 9, where we saw the need to train people to manage the infection prevention and control programs. Now, due to the COVID-19 pandemic, this deployment course was canceled, and then the instructor was also deployed. So there was such a need from all 3 services that we did our first ever virtual course, just in time training. So it wasn't the full 5-day, but it was hitting the key points to that course. We held it Monday through Friday in the afternoons through using leveraging Microsoft Teams and leveraging the Vital T program. We had all 3 services participating in our just-in-time training. We had all 3 services assisting us with that training. And we also had people in the area of operation throughout the world. We thought this new platform was a huge success and a model to use for future courses, especially if people were unable to travel. We leveraged through the Microsoft team. We were able to work in groups, go to separate classrooms, work in our class scenarios as we were in person. We continued to monitor what we're doing now through weekly call or once a month calls with our people in the AOR to assess using the Vital T, their infection prevention. Thank you for the question.
Awesome. Thank you very much, Ms. Crouch. So we have 2 questions on here. I see one from a Mr. Carpenter. He asks, how do I submit a question? Yesterday's panel didn't answer my question, but I answered everyone else to include it. I don't know the continuity of what he's saying. Mr. Carpenter, if you can send an inbox to us on Army Medicine, we will be able to directly answer your question. Thanks for your submission. And we have another question. Let's see if we can address this. The question is there a plan to expand virtual visits with nursing patient triage in acute care using nursing protocols? Can anyone answer this question?
I think it's, so we teed up the virtual medical center to be able to expand, but they're really owning the space of the increased coordination for telemedicine services. So I think, overall, there's been a definite increase in telemedicine across the MHS, but the specific strategy to expand nursing patient triage and virtual visits, I can't speak to that.
Okay. Well, thank you very much, ma'am. I think that is the end as far as questions that have been submitted on our pages. More than anything, to the panel, I just want to thank everyone for participating in today's discussion. This is a needed discussion. This is a first-timer type of discussion, being that it's all virtual with AUSA. And I think we did all a great job. If anyone has any closing remarks or comments, go ahead and feel free to share those closing remarks or comments. Anyone? Nope. Okay, I'll close it off, no problem. So I want to say to everyone, just thank you for participating, of course. The Office of the Surgeon General, Lieutenant General Dingle, thanks you for your medical expertise participating in today's discussion. Feel free to share away this podcast to anyone and everyone. They don't even have to be a medical background. Share it all around, share it to everyone. Let them be aware of the good things we've got going on here in Army Medicine. And I just want to say thank you again to everyone.
Thank you. Thanks for joining us this morning. Take care.
All right. I'm going to go in the solo mode real fast. Hold on. Let's take that off. Put it back on me. And in closing, I want to say thank you for participating in today's discussion. We have a few more panels going on today to include some command sergeants major and also another panel later on in the afternoon. Go ahead and check out the schedule that we have for Army Medicine in this AUSA virtual conference. And in closing, as I always like to say, Army Medicine is Army strong.